Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is new with thoracic surgery? Find out more right now. My guest this evening is Dr. Hwalek, a thoracic surgeon with MedStar Georgetown Medical Center. Ann, welcome to Housecall.
Thank you. Thank you for having me.
My pleasure. So briefly, Ann, tell our viewers about your professional background.
Sure. I'm a thoracic surgeon, and a thoracic surgeon is really defined by a surgeon who operates on the chest cavity. The easiest way that I tell patients that is I operate in the rib cage and on the ribs as well. So a surgeon that does that is often known as a cardiothoracic surgeon because the heart is within the rib cage, but that specialty is kind of divided out into a general thoracic surgeon and a heart surgeon. So I work on everything in the chest outside of the heart, and that makes me a general thoracic surgeon.
How interesting. Tell our viewers about your training. Where did you go to medical school and do your residency, etc.?
Sure. It's a long road of training to do cardiothoracic surgery. So I started out at Oklahoma State School of Osteopathic Medicine. From there, I thought I would be a family practitioner until I did my surgical rotation and fell in love with surgery. I then went to Loyola in Chicago for general surgery training. That's general surgery is normally 5 years. I took 2 extra years for research, so 7 years later. And then finally I went to fellowship at The Ohio State University in Columbus that just focused on chest surgery and cardiothoracic.
And what was it when you were in medical school and you rotate through all the different specialties? What grabbed you about surgery in general and thoracic surgery in particular that led you to take all those postgraduate years before you finally went on to practice your craft?
Yeah, that's a great question. And students often ask me that, how do you make that decision? And I think you make it piece by piece. So first you realize, if you want to be a surgeon, and the great side of that is you get to work with your hands every day. You get to see almost immediate results with your patients. Sometimes patients come into the operating room very sick and they leave stable, and you can tell their family they're going to do well. A patient can come into the operating room with cancer. They can leave not having cancer. There's a lot of amazing benefits that I saw in surgery with that quick change. And I thought, I really want to be able to learn how to provide that for a patient and a patient's family. So that was the first step, is surgery. And then the next step is what kind. There's so many different kinds of surgeons and so many great ways to help someone. Well, I found one of the most beautiful places to get to operate it with the anatomy is in the chest. So every day to get to see the ventilation of the lungs, the beating heart, it really is an amazing place for both active physiology and pathology at the same time.
Did you ever consider the other side of things, cardiac surgery?
I did, yeah. Certainly in fellowship, you spend a few months with cardiac surgeons and then a few months with thoracic surgeons. And the cardiac surgeons, they would definitely try to tease me, and those are incredible procedures, incredibly life-changing for people. But I just really enjoy cancer care. And thoracic surgery really allows you to work in a multidisciplinary setting and get to take care of cancer patients.
So what are some of the conditions that you deal with as a thoracic surgeon?
Yeah, it's wide ranging. So I work, with subspecialists and specialists from different aspects. So if you really think about what organs are going through the chest, well, the first one you always think of is the lungs. And We know that lung cancer is the most common cancer in the world. So certainly lung cancer is a very common cancer for us. But the lungs also have other diseases that can happen over time beyond cancer. So we can help the pulmonologist provide diagnosis and treatment for those, including emphysema or lung disease. The same time, a lot of lung infections happen in the chest. So we help diagnose the lung infection, treat the infection, sometimes with tubes, sometimes with surgery. The other main organ in the chest is the esophagus. So we do a lot of esophageal surgery. The esophagus is an organ that goes through 3 different areas: your neck, your chest, and your abdomen. So as a thoracic surgeon, you have to learn to operate in all 3 of those places in order to provide esophageal surgery. And then the last place is an area called the mediastinum. And this is the place between the 2 lungs in which a lot of cancers can sit or growths can happen. And we help resect those or even provide a diagnosis of what those are.
Let's circle back to the esophagus.
Yeah.
Since I'm a gastroenterologist, that of course is very important to me. What kind of esophageal disorders do you treat with surgery?
Yeah, the main one you can think of is cancer. So an esophageal resection for cancer. And that usually happens after people go through chemo or radiation. They have other treatments. And then at the time, right now, we still take out the esophagus even after those treatments. Another important one is hernias. So a hernia is just a hole anywhere in the body that's from normal tissue, but one can happen in between your abdominal cavity and your chest cavity, and that's known as a hiatal hernia. So patients can get those in. They can become very large, where the contents of their abdomen, their stomach, their small bowel, even their spleen can come into their chest. So we help repair that hernia. And then the last one to think about is a diagnosis called achalasia. And that is where the neurons in the esophagus aren't firing properly. So we help release kind of the tension on the esophagus and the muscle so that people can swallow easier and be able to pass through food through into their stomach.
With the achalasia, are you treating it with a classical surgical approach to cut the muscle fibers? Or are you also involved with some of the newer techniques where you partner with a GI endoscopist to go down and do peroral esophageal myotomy?
Yeah, that's 2 great techniques. Right now, I focus on the surgical side or the surgical technique, but we can now split the muscle fibers from inside the esophagus. But for young patients who have a certain type of achalasia, they benefit, and our results are almost about 90% resolution of their symptoms with a surgical myotomy or cutting the actual muscle tissue in surgery.
Let's circle back to what you said about lung cancer. As you know, the American Cancer Society and our colleagues in pulmonary medicine have advocated for a number of years frequent CT scans to pick up cancer when they're tiny little nodules and not big tumors. As a result, have you found with earlier detection that you're busier than ever dealing with these tiny lung cancers?
We are certainly busier than ever treating early stage lung cancers. And that has been a real tribute to the screening criteria. So patients that are over 55 who have a history of smoking, or they've quit smoking within a relatively short amount of time, their primary care physician might recommend this screening CT scan. And we used to try to do x-rays, but we realized that we weren't catching those early stage cancers like we can with the CT scan. And those scans have really helped us. So yes, we get calls all the time from our pulmonary colleagues with nodules, sometimes less than a centimeter, but we see change in them. We now may see lymph nodes involved in them. And per 1 or 2 screening scans, we now can almost offer them a curative surgery for lung cancer based off that scan.
Remarkable.
It's unbelievable. And the technology to be able to do it and to be able to see a patient that isn't in late stage cancer is really one of the most refreshing parts of my job.
And my understanding is they recommend doing these screening scans for about 10 years after you stop smoking. Is that still the standard of care?
Yes, yeah. And then yearly scans, so annual
Right.
scans for these patients, yes.
And the feeling is that cumulative radiographic exposure is still worth it, given the plus of early diagnosis and potential cure.
Absolutely, and we recommend a low dose CT scan that where the radiation dose is actually less than what someone would come in if they needed to go through the emergency department for an acute problem. The CT scan is a little different.
So with tonight's program, you may have a viewer who's in medical school or their residency, and they're considering thoracic surgery. Tell our viewers about a typical day as a thoracic surgeon.
Absolutely, I will certainly give my plug for what I think is a wonderful profession. But our days, we try to spend maybe 2 days in the clinic seeing new patients and our return patients, and then 3 or 4 days in the operating room. And we can go anywhere from working with lung cancer and resecting lung cancer to working on a hiatal hernia and reducing that hernia for a patient. And then we also help our colleagues in the hospital with seeing consults. And that's a lot of times we get consults for pulmonary infections and how to help best manage those. Or if there's really any issues in the chest cavity in which they need help with surgery on them, catheters or anything along those lines. So our days start early, as most surgeons do. Usually our operating rooms start by 7:30. Our clinics start just shortly after that. And then a full day will have 2 or 3 procedures in it and plenty of clinic patients to see.
So when do you typically leave the hospital?
It depends. Some nights, on my operative nights, I try to usually by 7 p.m. But on my clinic days, I'm out of here by 5 o'clock because, we push through and make sure that we get all our documentation in before we go.
And what is your night call like? How often do you get called out?
Yeah. I work in a group of 4 thoracic surgeons that cover between 2 hospitals in the MedStar system. And we take a week of call a month, including the weekend. And from that, emergencies probably every other month. So, we certainly don't have to go in every night like some surgical specialties do. But, there are some surgical emergencies, including with the esophagus. If the esophagus has a hole in it or an esophageal perforation, that is considered a surgical emergency and one that we would see that same night.
We're going to pause briefly for a public service announcement. More with our guest, Dr. Ann Hwalek, in a moment, and we'll be discussing thoracic surgery. We'll be right back. We're back with our guest this evening, Dr. Ann Hwalek, a thoracic surgeon at MedStar Georgetown Medical Center. And when we paused, we had discussed briefly your surgical approach to lung cancer. How is it decided then, after the surgery is completed, whether the patient needs radiation or chemotherapy?
It's a great question. And at Georgetown, we utilize a multidisciplinary approach in which we review the pathology, meaning the surgical specimen, what actually comes from the patient, to help us decide that. And when we look at it, we're asking ourselves 2 main questions. The first is, did we get all of the tumor? And the way that surgeons talk about this is in the term of margin. Is what we left behind clean of cancer? And if it's clean of cancer, that's a great sign. If there's still a little cancer left, that could be an indication for postoperative radiation. The next thing that we ask our pathologists to look at are the lymph nodes. And taking different stations of the lymph nodes or different locations of lymph nodes within the lung is very important to doing a proper cancer operation for patients. So if there's no cancer within those lymph nodes, generally patients don't need any therapy. However, if that cancer is spread into the lymph nodes, then chemotherapy or drug therapy is usually utilized.
Have you had many patients where you do early surgery? where it's just a tiny nodule and the lymph nodes are clean and there's no need for chemo and radiation, and you've told the patient that they are cured.
Absolutely. And that's the best clinic appointment that I have.
I bet.
Get to hand them their pathology report and tell them that they are cancer-free. Most of our patients have a smoking history. So it's at that moment that I get to reinforce how important it is for them to continue to no longer smoke. And then I also let them know that they'll be going through surveillance scans, CT scans, and we will be watching for this cancer over the next 5 years.
I'm sure a challenge for you all that are thoracic surgeons is planning your surgery for cancer, because clearly, as you said, the broader your margins, the greater the likelihood you've got it all out. However, I would imagine that the bigger your margin, the more you're going to reduce their lung capacity.
Absolutely.
How do you strike a balance between getting the cancer cured, hopefully, and at the same time not compromising their postoperative breathing?
Absolutely. That's a wonderful question, and one I get very often, is people don't want to lose their lung function. I can certainly see how that's so important to these patients. Well, before surgery, we do a group of testings called pulmonary function tests. And those tests have allowed us over large series of patients to know, based off the amount of lung that we need to resect, what we can anticipate for their lung function to be after. And for the most part, we offer resection to patients that we expect them to have a full recovery or pulmonary recovery. So it's a little bit of a ratio of math. We see their tests before, we realize how much lung we need to remove, and then we give them, and then we can estimate the number of how good their lung function would be after. If that amount of lung function they have remaining would allow them to need mechanical ventilation or oxygen afterward, then we talk about other methods of therapy for them, including radiation as opposed to surgery. And that's a risk-benefit discussion with our patients, saying your lung function isn't quite what we need it to be able to take out this size tumor.
Do you automatically remove an entire lung, or do you try to preserve lung function there by making a partial resection?
Yeah, it depends on what kind of tumor it is. So some tumors we can just, what we refer to as, do a wedge resection, a partial taking of the lung, in which only encapsulates the tumor. Now, for most patients, however, we do a lobectomy, and the lobe or the lungs have 5 lobes, 3 on the right side, 2 on the left. For a cancer operation, many times we need to take the entire lobe, because that not only contains the cancer, but the drainage pattern of the cancer as well. So it takes the lymph nodes around it, and that way we can ensure that our pathologists, in fact, tell us afterward that we have negative margins. Let's
shift gears to discuss a very important topic for thoracic surgery, and that's trauma and injury. Mm-hmm. So let's take what I suspect is a typical case for you and your partners. You've had a busy work day, you finally get home at 7:30. You're just sitting down for dinner when your cell phone goes off. Dr. Hwalek, we have a gunshot wound in the emergency room at Georgetown Medical Center. Talk our viewers for what happens then at that time.
Yeah, absolutely. That always gets everyone's adrenaline going. You know, a gunshot wound, and certainly a gunshot wound that goes to the chest, because there's so many important structures there. There are 2 major incisions that we might need to make on someone to figure out what's going on. And the first is a median sternotomy, and that's opening up the breastbone in the center of their chest. Now, this depends on where the gunshot is, and if we think that it affects the heart or the great vessels that pump to the rest of the body. If we think that it actually involves more of the lungs and isn't so much in the middle of the chest, but on the outside, then we would make an incision called a thoracotomy, and that's in between the ribs. We would open up the ribs and then evaluate the lungs based off that. So really, we use not only physical exam to look at where the gunshot was, testing, including ultrasound and echocardiogram. And if a patient comes in and is relatively stable enough, we can even take pictures to know exactly what the damage of the bullet has done. That all depends on if the patient is doing well or if the patient's blood pressure is dropping and they might need some blood products. Then we go more emergently to the operating room to figure out what the problem is.
I would imagine that it sometimes can be a challenge for the emergency room physician, whether he should call a thoracic surgeon or a cardiac surgeon. Is that ever a dilemma?
It is, but these days we have so many great trauma surgeons who understand exactly how to evaluate these wounds. So they would help guide the ER physician through that and know exactly who needs to be called. For the most part, if you call the cardiac surgeon, or they would be very quick to respond and talking through with you to make sure that we have the right person for you.
When do you decide that you can just leave a bullet in and not intervene?
Yeah, that's a good question. Bullets, as they come through because of the heat that they put off, are for the most part sterile as they enter. But bullets that are close to any of the major blood vessels that surround the lungs or the heart, those are the most likely need to come out. Now, we have had cases where patients come back from, if you work in the Veterans Hospital, who might have shrapnel or retained bullets in their chest, and they usually do not cause a problem. For those patients, at times, they've had it there for years, and it can be safe to leave in place.
Now, as you know, another emergency is a pneumothorax, a collapsed lung.
Mm-hmm.
Talk to our viewers what are the causes of a collapsed lung and how you approach it.
Yeah, great question. That's at times something that will make people come to the emergency department and see us urgently rather than in the clinic. And what a pneumothorax is a decrease that there becomes a space between the lung and the chest wall. As we breathe and sit here today, our lungs touch the side of our chest wall and there's no space. But if air continues to accumulate in that space, it can actually push in on our heart and be an emergency. So this is why when you come and if patients are having problems breathing, very commonly they get a chest x-ray. And a chest x-ray can see that pneumothorax and help decide what we need to do. For most pneumothoraxes, depending on the size, a small caliber chest tube, usually about the size of your pinky finger, will be inserted between your two ribs, and that will help evacuate the air. For many patients, that's all they need. Once the lung is re-expanded, we can pull that tube and they do just fine. Some patients will need to go on to surgery for that because they have a weakness in their lung known as a bleb, and that's a small air sac that continue to leak air. That would be one of the main reasons we would actually go to surgery to fix it.
What happens if the pneumothorax is traumatic? Somebody's been stabbed.
Yeah, those are certainly, chest tubes are in place for those. And then many times there's also a component to that is a hemothorax. So not only is there air in their chest, but also blood. And we first drain those with chest tubes. And then if we need to go in and make a thoracotomy incision to actually look at the lung and resect any lung that is bleeding.
So you don't try to oversew the damaged lung, you just resect it.
Yeah, for the most part, we use a stapler to resect that area. Lung is pretty hard to sew to, unfortunately.
Yeah.
It would make our job easier if we could.
Right, absolutely. So tell us about your unique opportunity working at MedStar Georgetown Medical Center. What are some of the exciting things going on there?
Sure. We offer a procedure here called CRATS, and that's a combined robotic assisted thoracoscopic surgery. And when people have, as we talked about in our lung cancer staging, it's important to not only know what's going on in the lung, but also in those lymph nodes that drain the lung. One of the ways that we are able to do that is using a bronchoscopy that we put down while patients are asleep into their airway, and we look with ultrasound at those lymph nodes. Patients at times can get that procedure before they go to surgery to help us understand what the lymph nodes are doing. But we're working with our interventional pulmonologist here at Georgetown and combining so the patient goes to sleep under one anesthesia event in which they then not only have the bronchoscopy and their mediastinal lymph nodes looked at, but also they help us locate the tumor within the chest to help it to make sure that it's easier to find for us in surgery. This can help us make a smaller resection And it can help the patient for only having to come into the hospital and go under general anesthesia once.
You mentioned robotic surgery. Are you using the Da Vinci equipment?
Yes, we use the Da Vinci device. We actually have two. One just within the last month here at Georgetown arrived, and that aids us in doing robotic surgery.
What do you think is some of the future developments with thoracic surgery? What do you think you'll be doing in 10 years? What's being discussed at your meetings?
Yeah, great question. I think robotic surgery is, it is now here, and it is very common for patients in the United States to have a robotic resection. But I also think through doing the endoscopy and going in through the airway with the bronchoscopy, we will be able to start offering, drug therapy. Right now we mark our tumors, but that could also, we could get down to doing smaller and smaller surgeries for these patients and being able to offer them more and more minimally invasive procedures.
Since Georgetown is a teaching hospital, do you have much opportunity to teach the medical students, interns, residents, and fellows?
Yes, we on the thoracic surgery service, we work with the chief resident, a mid-level resident, and an intern, which is a first-level resident, every day. We also are lucky enough to have a medical student or two on our service. And so every clinic patient, every operative patient we get to see, we get to share in the knowledge and the learning with them, with these students and these residents.
And what is your favorite part of your day?
It's getting to work with those residents and these residents, they're training to be surgeons. They're young surgeons whose skills are they grow exponentially as you work with them. And working with the higher level residents on their technical skill, working on the first year residents, working on their knowledge base to help to be able to treat and diagnose our patients best. And then seeing the excitement of a medical student. And when they put two things together that they've heard in the classroom, they get to see it, as when we look at a patient, we look at, every class they've had, their pharmacology, their pathology, their physiology all at once. And it's really a great thing to get to see them to put it all together. I really enjoy that.
And if our viewers have any questions, how can they reach you?
Yeah, great question. Through the MedStar Georgetown, through our website, directory is a great way. On there is my clinic phone number and email if anyone needs to get a hold of me. And certainly would love to, if any thoracic issues come up or any questions about the things we talked about today, I'd be happy to answer.
Thank you for joining us for a very informative interview.
Thank you.
My thanks to Dr. Hwalek for a very interesting interview. My thanks to my team at the station. And most important, thank you to the viewer for joining us this evening. If you have any questions, you can reach me through my practice website listed at the bottom of the screen. As for our next topic, it'll be Dr. Bruce Luxon, a liver specialist at Georgetown Medical Center, and we'll be discussing liver disease. It's going to be a very interesting show. See you then next time for another edition of Housecall. Good evening.